Transthoracic ultrasonography is a well-established yet underutilized imaging modality in respiratory medicine. It allows for real-time and mobile assessment of thoracic disorders and can potentially augment the physical examination of the chest. The objectives of this lecture is to review the machine knobology and transducer probe selection and orientation as it pertains to thoracic ultrasonography, to learn the ultrasound anatomy of the lung and thorax, and lastly, to learn how to diagnose a pneumothorax via thoracic ultrasonography. This is what the basic keyboard of an ultrasound machine looks like. For this lesson, we will concentrate on 4 functions. It is important to get to know your ultrasound machine before attempting a bedside exam. Nothing looks worse than an unprepared clinician fumbling away with knobs and buttons. You might be the best ultrasonographer in the world, but if you don't know where the power button is, your credibility and reputation can be jeopardized. Let's begin. The gain is the equivalent of the volume button on your radio and controls the overall amplitude of the returning sound wave to the transducer. The gain can be likened to the brightness adjustment on a television. Going up on the gain makes the image look brighter, and going down makes the image look darker. The gain should be adjusted to maximize the contrast between tissues. M mode, or motion mode, produce reflections off the boundaries of organs, thus allowing the determination of velocity for specific organ structures. M mode uses acoustic waves to determine a structure's movement over time. And lastly, 2D mode, which returns you back to your starting screen. Here are the 3 transducers most commonly found on the ultrasound machines. Here is the linear, curvilinear, and phased array transducer with their corresponding frequency and resolution. The word transducer and probe can be used interchangeably. For the thoracic ultrasound exam, we will mainly use the phased array probe because of its small footprint design, allowing scanning between the rib interspaces. Once the abnormality has been identified, the linear transducer can be used to obtain a more detailed image. A low-frequency probe, usually between 2 to 5 MHz, with a curvilinear shape is suitable for screening of superficial and deeper structures, whereas a high-frequency probe, between 5 and 10 MHz, with a linear shape is used for refined assessment. Higher frequency allows for superior resolution closer to the probe, but at the cost of reduced penetration. The ultrasound machine is positioned so that the screen is easily visible from the operator's work position. Ambient lighting is reduced to maximize screen contrast. Liberal application of gel is the final step prior to scanning. It is advisable to hold the probe like a pen, with the outer part of the hand in contact with the skin. The sonographer should maintain visual contact with the screen while the dominant hand moves the probe across the area of interest, and the other hand is used to optimize the digital image by adjusting the depth and the gain. Findings can be compared with the contralateral side, which can be used as a control. Place a transducer with the indicator pointing toward the patient's head, as shown by the red dot. This is the long axis or the sagittal plane. You should see the following image with the head of the patient toward the left of the screen and the feet toward the right of the screen. There are 8 standard evaluation locations, 4 per side, that should be examined when performing the thoracic ultrasound exam. The borders are the peristernal, the anterior axillary, and the posterior axillary line. Areas 1 and 2 denote the upper anterior and lower anterior chest, whereas areas 3 and 4 denote the upper lateral and basolateral chest respectively. Also important to note that the extrapleural air, as in the case of a pneumothorax, is best seen in the anterior zone, whereas consolidations and effusions are best seen in the posterior lateral zones. Taking a closer look at the pleura of the lungs, one can see the chest wall, which consists of multiple layers of echogenicity representing muscles and fascia. The hyperechoic line is comprised of the parietal and visceral pleura. Ribs appear as convex structures, with its associated posterior acoustic shadow interrupting the pleura. If the probe is turned 90 degrees longitudinally, within the intercostal space. With the indicator pointing toward the right, the pleura will then appear as an uninterrupted line. Physiologically, the two layers of pleura glide over each other during inspiration and expiration, which gives rise to the lung sliding sign on real-time ultrasonography, which is best appreciated on longitudinal scanning. Its presence has a high negative predictive value for the diagnosis of a pneumothorax. A reverberation artifact, also known as A-line, is present within the lung, as well as a single comet tail artifact. Aerated lung parenchyma cannot be visualized on transthoracic ultrasonography. In fact, air is the enemy of ultrasonography. The large change in acoustic impedance at the pleural-lung interface, however, results in horizontal artifacts, so-called reverberation artifacts, or A-lines, that are seen as a series of echogenic parallel lines equidistant from one another below the pleura. A-lines indicate normal lung surface with a dry interlobar septa and have a 90% sensitivity and 67% specificity for a pulmonary artery wedge pressure that's less than 13 millimeters of mercury. B-lines are laser-like vertical artifacts that obliterate A-lines. B-lines generally extend to the bottom of the screen and are considered pathological and indicative of interstitial syndrome, like pulmonary edema and pulmonary fibrosis. Lung rockets refer to the presence of several B-lines. A few short vertical comet tail artifacts can be seen at lung bases in normal individuals. Acute respiratory distress syndrome and pulmonary fibrosis tend to give rise to more patchy involvement and spared areas, and a non-homogeneous distribution of B-lines, as well as an irregular thickened or fragmented pleural line. From the lateral position, with probe indicator pointing toward the patient's head, you should be able to obtain the diaphragmatic view. The diaphragm is useful to identify, especially before any pleural procedure, to ensure that the needle insertion site and trajectory will remain in the thorax and not inadvertently in the abdomen or within abdominal structures. The diaphragm typically appears as an echogenic line, and downward displacement can be appreciated during inspiration. Putting together what we have just learned, the diagnosis of pneumothorax can be made. Place the phased array transducer in the third and fourth intercostal space between the peristernal and midclavicular lines. The first step is to identify the contiguous ribs on either side of the field. Next, the pleural line is identified between and under the ribs. The four key features of a pneumothorax are 1. Absence of lung sliding, 2. The absence of B-lines, 3. The absence of lung pulse, and 4. Identification of lung point. The absence of normal lung sliding and lung pulse, exaggerated horizontal reverberation artifacts, and the absence of B-lines are reliable signs of a pneumothorax. The lung pulse is caused by cardiac oscillation and refers to the subtle movements of the visceral pleura in relation to the parietal pleura. In certain concomitant diseases, including diaphragmatic paralysis, prior pleurodesis, or pleural adhesions and emphysema, the sensitivity of ultrasonography for the diagnosis of pneumothorax may be lower. Ultrasonography may be used routinely to screen for post-procedural pneumothorax after transthoracic interventions, as well as after transbronchial biopsy, and may obviate the need for routine post-procedural chest X-ray. M-mode is another tool that can be used to solidify the diagnosis of a pneumothorax. M-mode is a way to look at the ultrasonographic image as a strip of data over time. Normal findings is the seashore sign. It is linear on the top and granular on the bottom. Abnormal findings looks like a barcode. It is linear on the top and the bottom and is indicative of a pneumothorax. Lung point sign is the inflection point of the pneumothorax. Here is the point where lung sliding and no lung sliding can be appreciated. You can see the comet tail artifacts coming down on one side, but not on the other.